Here's the step 1 question students dread. A patient has an acute myocardial infarction, another has an ischemic stroke, another has tuberculosis. All three have dead tissue. Which type of necrosis does each one have, and why are they different? If you've been memorizing a list, this session replaces that list with a single predictive framework based on the biology of the tissue itself. Let's go. One question predicts the necrosis pattern in almost every vignette. When the injury hits, what happens to the tissue's proteins and the enzymes that digest them? If proteins denature and coagulate, the tissue firms up and preserves its shape. That's coagulative necrosis. If enzymes stay active and digest everything, the tissue liquefies and loses architecture. That's liquefactive necrosis. Most other named types are variations driven by the unique properties of a tissue or a pathogen. Keep the core question in your head: what happens to the proteins, and the patterns will fall into place. Type 1. Coagulative, the default. Think ischemia in any solid organ. Cells die, but the biochemical environment inactivates the lysosomal enzymes that would otherwise digest the tissue. With those enzymes shut down, proteins denature and cross-link, and the tissue firms like a cooked egg. Under the microscope, the architecture is preserved. Ghost outlines of cells are still recognizable, yet the nuclei are gone. This is heart, kidney, spleen, liver. The classic case is myocardial infarction, pale, firm infarct, eosinophilic cells with lost nuclei, architecture intact enough that you can still trace myofiber outlines. Expect coagulative necrosis whenever a solid organ loses blood supply. Now the exception step 1 loves, the brain. Brain ischemia does not produce coagulative necrosis, it produces liquefactive. Why? The brain is lipid-rich and packed with hydrolytic enzymes from neurons and glia. The ischemic conditions do not sufficiently denature those enzymes. They remain active, and they digest the dead tissue into liquid debris. Grossly, the infarcted area softens, then evolves into a cystic cavity containing fluid and debris, with complete loss of structure. Microscopically, the architecture is gone. Say it and lock it in. Ischemia in solid organs is coagulative, except the brain, which is liquefactive. Type 2. Liquefactive, with two distinct triggers worth separating. Trigger 1 is brain ischemia. We just covered it. Intrinsic enzymes digest the tissue, culminating in a cystic cavity containing fluid and debris with complete loss of structure. Trigger 2 is pyogenic bacterial infection. Pyogenic means pus-forming. Staphylococci, streptococci, many gram-negative rods. These organisms recruit swarms of neutrophils. Neutrophils pour out hydrolytic enzymes that digest both pathogens and the surrounding tissue. The result is pus. If that pus walls off, it becomes an abscess. By definition, an abscess is localized liquefactive necrosis. So liquefactive is the endpoint for brain infarction and any pyogenic abscess, both through active enzymatic digestion. Type 3. Caseous, the pathonomic pattern you should instantly associate with tuberculosis. Caseous means cheese-like, soft, white, friable, crumbling. You will also see it with certain fungi such as histoplasma and coccidioides, but the reflex on step 1 is TB first. Mechanistically, it's about host pathogen stalemate. Mycobacteria have mycolic acids in their walls, waxy lipids that resist digestion by macrophages. The immune system cannot clear them, so it forms granulomas. Epithelioid macrophages and Langhans-type giant cells ring a central zone of necrosis that dies from hypoxia and toxic cytokines. Because bacterial lipids resist complete digestion, you don't get the firm, preserved architecture of coagulative or the full dissolution of liquefactive. You get amorphous, granular, pink debris with no cellular outlines. On histology, the hallmark is that acellular eosinophilic center, structureless pink material collared by granulomatous inflammation. See this? Think TB until proven otherwise. Type 4. Fat necrosis, in two settings with a Usmle nuance. First setting, acute pancreatitis. Acinar cells rupture and release lipase into surrounding tissues. Lipase cleaves triglycerides in parapancreatic fat into free fatty acids. Those fatty acids bind calcium ions, saponification, forming chalky white deposits on the peritoneum. Microscopically, you'll see shadowy dead adipocytes rimmed by basophilic calcium. Importantly, the calcium is consumed by those deposits, lowering serum calcium. So hypocalcemia and acute pancreatitis is explained by fat necrosis via saponification. Second setting, breast trauma. Blunt injury ruptures adipocytes, leading to the same chemistry. Fatty acids bind calcium and calcify, creating a firm, sometimes tender lump that can mimic a mass. Now, the nuance students often trip over. Technically, the pancreatic parenchyma undergoes a form of liquefactive necrosis because enzyme-rich tissue digests itself, but Usmle logic focuses on the parapancreatic fat. When a vignette says pancreatitis and necrosis, the test answer is fat necrosis. If both liquefactive and fat necrosis are options in pancreatitis, choose fat necrosis. Type 4. Fibrinoid, the vascular pattern. It occurs only in vessel walls, small arteries, and arterioles. The classic trigger is immune complex deposition. Antigen-antibody complexes lodge in the wall, activate complement, recruit neutrophils, and the enzymes they release damage the wall. Plasma proteins, including fibrin, leak into the compromised wall, giving it a homogeneous, bright pink, fibrin-like appearance on H&D. Diseases to anchor: polyarteritis nodosa, malignant hypertension, rheumatic fever, and SLE vasculitis. In PAN and SLE, immune complexes drive the process. In malignant hypertension, shear pressure forces plasma proteins through the wall. In vignettes, the signal is arteriolar damage with bright pink walls in the context of one of these diseases. This histology helps explain end-organ injury in malignant hypertension. Arteriolar fibrinoid necrosis leads to renal and retinal damage. Type 6. Gangrenous, a clinical descriptor rather than a unique microscopic pattern. It describes extensive ischemic necrosis in a limb or large tissue mass. Dry gangrene is pure ischemia without infection. Mechanistically, it's coagulative necrosis. The tissue shrivels, dries, turns black. Think mummified toe in peripheral vascular disease and diabetes. Wet gangrene is ischemia plus bacterial superinfection. Now you have coagulative necrosis from ischemia combined with liquefactive necrosis from bacterial enzymes and neutrophils. The tissue is soft, moist, foul-smelling, often with gas bubbles if Clostridium perfringens is involved. That's a surgical emergency. The classification in a vignette is straightforward. Black, hard, shriveled toe, dry. Soft, putrid, gas-forming tissue, wet. Now the vignette traps, where recall becomes reasoning. Trap 1, the renal infarct. A patient with atrial fibrillation has sudden flank pain. CT shows a wedge-shaped pale area in the kidney. That wedge is an infarct. The kidney is a solid organ. Ischemia produces coagulative necrosis. Architecture preserved, nuclei lost. Don't overthink it. Trap 2, the brain exception under pressure. A 70-year-old had a stroke 2 weeks ago. Repeat imaging shows a fluid-filled cavity in the MCA territory. That end-stage cavity is liquefactive necrosis. Do not mark coagulative just because it's ischemia. Brain plus ischemia equals liquefactive every time. Trap 3, the pancreatic nuance. A patient with acute pancreatitis has elevated lipase, chalky peritoneal deposits, and low serum calcium. The necrosis in peritoneal fat is fat necrosis via saponification. The calcium drop is due to fatty acid binding. If the choices include liquefactive and fat necrosis in this context, pick fat necrosis. Trap 4. Fibrinoid in context. A patient with severe hypertension has headache and visual changes. Renal biopsy shows bright pink homogeneous thickening of arterial walls. That's fibrinoid necrosis. Mechanism: plasma proteins forced into damaged walls under extreme pressure. This is how malignant hypertension injures renal and retinas. Let's summarize in 3 moves. First, the framework. Ask what happens to proteins and enzymes when injury hits. Coagulative means proteins denature and the shape is preserved. Liquefactive means enzymes stay active and digest the tissue, wiping out architecture. The other named types are variations guided by tissue biology or pathogen features. Second, the organ map you can carry into any vignette. Ischemia in solid organs, heart, kidney, spleen, liver, produces coagulative necrosis. Ischemia in brain produces liquefactive. TB and certain fungi produce caseous with cheese-like debris and granulomas. Pancreatitis and breast trauma produce fat necrosis with saponification and calcium deposition. Pancreatitis can drop serum calcium. Vessel walls with immune complexes or extreme pressure show fibrinoid necrosis. Ischemic limbs show gangrene. Dry is coagulative only. Wet adds infection and liquefactive. Third, the traps. Brain ischemia is liquefactive every time. Pancreatitis with chalky fat and hypocalcemia is fat necrosis, not liquefactive. Fibrinoid means vessel wall injury and points to PAN, malignant hypertension, rheumatic fever, or SLE. Dry turning wet means bacteria join the party. Subscribe to Step Genie. Every session builds mechanism first, then walks the vignette logic so you can choose the right answer under pressure. Drop your hardest pathology topic in the comments. Next week's episode, acute versus chronic inflammation with the same framework-driven approach. See you there.